Now we can actually get started. So thank you everybody for joining us for the, I guess you could say, holiday session of the CCHCSP seminar series. And I am happy to have with us Dr. Stewart Nichols. He is the Strategy for Patient-Oriented Research Facilitator and a Senior Clinical Research Associate at the Ottawa Hospital Research Institute. He is a member of the Public Health Agency of Canada, Health Canada Research Ethics Board, and holds editorial positions at the Journal of Research Ethics and Journal of Empirical Research on Human Research Ethics. He has published widely on the topic of informed consent, population health ethics, as well as challenges raised by more pragmatic real-world research approaches, including the use of routinely collected data. And today, that's exactly what he's going to be talking with us about, is the ethical context of using big data. So I'm going to hand it over to you, Stuart, and thanks again for joining us.
No, thank you, and apologies to everyone for the delay caused by the technical issues. So I guess I'll just say next slide as I go through. So yeah, if we can progress to the next slide. So just before I start, I don't have any conflicts to declare other than the fact that myself and Eric Benchmall, who spoke to this group previously, co-authored a chapter in this book, and technically I should earn some royalties, but I don't think I've ever seen any, so there's nothing there to declare. Next slide, please. So as was on the advert coming round, I hope to describe a sort of range of ethical challenges associated with using sort of nominally big data, but particularly I'm going to focus on the secondary use of routinely collected data in child health research. I want to highlight some of the ways that these can affect the conduct of research and hopefully give some examples of resources and sort of sites, places to go that might help you when you face these challenges. Thank you. Next slide. So you've probably seen lots of publications in the popular press, perhaps, around sort of big data. It's the end of scientific research as we know it. So there's some animations just to click through on this one, if you don't mind. It's even made its way into popular culture. Dilbert's even talking about big data. And if you click through again, please. A challenge with sort of big data is that often when people talk about big data, they're talking about very different things. So people will often use terms like big data, machine learning, AI even now to talk just as sort of catchphrases that perhaps are being used to describe other types of research that we've always done using large data sets. So I think we have to be careful when we talk about big data and be clear what we're talking about. And for that reason, I'm going to primarily talk about the secondary use of routinely collected data, which tends to be large data sets. Next slide, please. So this is commonly how big data is described. I'm only going to briefly touch on this now, but just to say that it's described in terms of 4 or 5 V's. Velocity, which is about the sort of constant streaming of data that sort of characterizes big data compared to other types of data. This might be apps, monitoring apps, bedside technologies, and so forth. There's also the verity or variety of the data forms. Not only the health administrative data and traditional health data, but again, the apps, the wearable devices, and particularly linking these types of data together. Value, I'm not going to say much about that, but veracity is a particularly relevant issue when we think about research using these large data sets. And I know Eric Benchmall in his talk talked about validation work and the importance of validation, and I'll return to that later. But just to say that because this data was not collected for research purposes, we have to be particularly mindful of that. And then finally, volume, and I think this is often what people are trying to characterize when they talk about big data, just the sheer size of the data sets that people are working with now. And when we talk about health administrative data, EMR data, those things, there's huge amounts of data in there. So that's often what people mean when they talk about big data, and that's primarily where I'm going to focus my area today. Next slide, please. And of course, we have different types of data, as I mentioned. But even within the sort of secondary use of health-related data, we can talk about clinical trial data, increasingly genetic or microbiome sequencing data, biological specimens, as well as that routinely collected health administrative data. And one of the characterizations of this field is the ability increasingly to link these data sets together to sort of further our understanding of health conditions. Next slide, please. So as I said, I'm going to focus mainly on routinely collected health data because I think that's the dominant form of research at the minute. And this is defined by Eric Benchimol and colleagues as data collected without specific a priori research questions. And so the types of data that might fall under this include disease registries, primary care databases, health administrative data, the EMR, and again, there's a couple of animations just to click through as we go along. So Statistics Canada holds a number of these data sets. And if we click through again, I'm including surveys here, not one-off surveys, but things like the Canadian Community Health Survey, where they have regular surveys conducted of the national population. And so these are routinely implemented, but they don't necessarily have that a priori research question. They're data collection tools that other researchers can use to investigate their own research questions. Next slide, please. So at this point, I just want to briefly mention the strategy for patient-oriented research as it relates to this field. Next slide, please. And so, as you may well be aware, the strategy for patient-oriented research is a program funded through the Canadian Institutes of Health Research. And as part of that, they have funded a number of provincial and territorial SPOR support units. These are methodological support units. And Ontario has several units, a main central coordinating center, and then several smaller units. And these include methodological units with special expertise in using routinely collected data, large data sets. So many of you have probably heard of ICES, or what you might have previously heard as ICES. And that's an Ontario-based institution, the Institute of Clinical and Evaluative Sciences, and their specific remit is around this work. But there's also the Ontario Child Health SPOR Support Unit, which is led by Sick Kids and CHIO, and again, which has a particular focus on supporting researchers across a number of different areas, but including the use of large data sets with a particular focus on child health research. So those are two particular useful resources for investigators here. Next slide, please. So often there's a motivation around the use of routinely collected data. And one of those is this issue of what's been talked about in terms of research waste. If we can go through the next slide, please. So this was a figure from a publication by David Moore and colleagues. And that itself was an update from a 2009 paper by Ian Chalmers. And the authors sort of postulate a number of areas where there are inefficiencies or waste in the research pipeline. And I just want to, if we can click through just to highlight one area. In this latest iteration, they highlight the poor reuse of data as a sort of area of research waste. If we go to the next slide, please. And there's a sort of not only a financial argument to this, but there are sort of two ethical prongs, if you will, to support this. One is that if we have information collected already that we can repurpose for research, then perhaps we can also leverage that in a way that we don't have to maybe spend as much money, but we could also fund other work. And so if we think about the research enterprise more broadly, we can potentially increase the utility or the benefits to be gained because we don't have to fund this primary data collection again. The second ethical argument to support this is around the sort of minimization of burden. If we already have data that can address our research questions, we don't need to conduct new surveys or potentially invasive procedures or data collection interventions. And so we sort of minimize the burden on patients in terms of time and effort, but also if some of these may involve risk, then we take away some of those risks. So again, those are sort of two strong ethical arguments to try and maximize the use of this data that we already have. And if we just click through, so authors like John Ioannidis have argued for this, and they've also argued that one of the things we should be doing is collecting the metadata, so the data about the data sets themselves, and making that available, and also registering our analyses so that we're not having duplication of effort and redundancy with investigators investigating the same questions, we're using the same data sets. So it's some of the similar arguments to the development of Prospero, which was the registration site for systematic reviews. Next slide, please. And so this has particular saliency to child health research. We know, for example, that there are the gaps in the care of children through inappropriate or potentially ineffective healthcare being delivered because research hasn't addressed the needs of children. And this can be because of a number of reasons. You know, we might have small sample sizes in terms of the conditions of interest, making it difficult to conduct research. Often the outcome measures or the endpoints or the instruments used in those studies haven't been validated in children. And there are ongoing challenges in terms of things like consent and sort of trying to balance the inclusion of children in research whilst also, you know, protecting them, as they're often considered one of those vulnerable populations we have to be particularly mindful of with research and primary data collection. So for these reasons, the ability to leverage existing large-scale health-related data might be particularly enticing in the child health context. Next slide, please. So I'm going to talk about some specific issues, but I also want to talk about some issues that probably apply generally, whether or not you're doing research in children or adults. So next slide, please. And before I get into those, I just want to sort of go back to research ethics broadly. So research ethics is about thinking through what research we should be doing and how we can best protect those who take part in research while still doing good science. And the reason we're concerned about this is because often the people who take part in research are volunteers who themselves will not necessarily benefit from that research. Obviously, in some cases they might, but often it's altruistic behavior. And so if people are giving up their time, exposing themselves to risk without necessarily the potential for themselves to benefit, we have to think carefully about the research that we allow and how that's done. But this latter part about still doing good science, I think, is often lost in the discussion about regulation and governance, insofar as we have to strike a balance and not have regulation or governance that's overly restrictive and stops us doing socially valuable research. And so this is an area, I think, where it's been brought to the fore, perhaps, when we're thinking about secondary use of existing data, because often the risks are more minimal and the potential for benefits is greater. So when we think about research ethics, there are a number of ways we sort of go about in terms of practically working. So one is to create guidelines that researchers and other stakeholders can follow, but also there's the work of the Research Ethics Board, and that's central to the process of considering those risks and benefits. But there's a secondary aspect, which again, I don't think gets as much focus, but is particularly relevant when we think about the secondary use of routinely collected data. And that's the role that these governance structures have in terms of promoting public trust in research. And the fact that by having these governance structures and maintaining public trust, we maintain the willingness of people to participate in research, but also to allow us to use that data. And so I think there's this secondary part, which I'll refer back to as I go along, where this notion of trust is essential. Next slide, please. And so as you're all aware, I don't think I really need to tell you about TCPS2, but all I want to say here is that whilst there are a number of chapters and a lot of detail, a lot of this boils down to three main principles. One is respect for persons, and that's often traditionally how we operationalize that is through individual informed consent, but also we have privacy and confidentiality processes. There's concern for welfare. And again, this is operationalized through those risk and benefit assessments that are done particularly by the research ethics boards. And then there's the principle of justice. And this is about thinking about not overly burdening individuals or certain populations, but also the converse of not excluding certain patients and populations from research. And again, when we think about child health research, balancing those protections, but also the fact that we don't want to exclude people because then we won't have relevant information about how to provide good healthcare. There is a balancing act there. And how we apply these principles might differ depending on whether we're thinking about trials or studies that are directly intervening on people versus studies where we make use of data that's already been collected. Next slide, please. So as I mentioned, consent is commonly the way we operationalize the principle of respect for persons. And whilst that's a generally accepted process, there are exemptions, and I'll get to this shortly. But TCPS2 covers this in chapter 5, and that I would direct anyone who's interested to review that chapter in the latest update. Next slide, please. So I just want to, again, highlight that tension or those competing aspects, which has been highlighted when we start to think about biomedical data, large-scale research, in the sense that there's been a sort of shift in thinking, or a gradual sort of movement in terms of trying to make that adjudication between those individual rights and claims to consent and rights to privacy, with sort of more collective claims about the benefits to be gained from research. And people are increasingly talking about this principle of solidarity, that whilst we maybe not have an individual responsibility to take part in research, there's responsibility to do research generally, and how do we manage that? Next slide, please. And of course, we have different approaches to consent, and I don't have time to go through all the different options and facets here, but in the context of the sort of research I'm talking about today, we may have that individual level specific consent. So particularly, for example, say longitudinal cohort studies or something like that, we may have an individual consent. But if that consent was for a specific purpose and a specific research question, if someone later comes back and says, would like to use that data, we have to then consider, is it practical to go back and reconsent everyone for these other alternative research questions and analyses? How is that to be managed? And so there's now increasing interest in alternative to that sort of specific individual research project style consent, and the use of what's sometimes called broad consent, in which the sort of future uses of that data or the samples or whatever are not necessarily specified, but it's an attempt to try and meet that principle of respect for persons in a way that doesn't stop us doing useful, socially valuable research. And so I think one of the things I would say here is that if you are going into prospectively collecting data in a large scale, one of the things to think about is what form that consent should take, because it's certainly easier to prospectively consider this. And if you think that there might be secondary uses to that data, build some sort of open consent or broad consent model, as opposed to solely working with a specific project-specific consent, and which may be difficult to retrospectively update or amend. Next slide, please. And while consent is a sort of general big topic around research and data collection generally, I think one of the particular areas that's relevant to child health research is this question of how do we manage consent or reconsent if children have been enrolled in studies. Again, the example being this sort of longitudinal cohort study, or a study in which they were enrolled as children, but then they reach an age of majority or age of maturity. And how do we manage that? Next slide, please. And this is further problematized because the sort of definition of reconsent and how that's operationalized really does vary when you look at the literature. There's different thresholds, different approaches, and so forth. We can have maybe two broad buckets. One is where you repeat the whole process. So for that child, they would reconsent to the whole research study. The difficulty there is, of course, if they decline or refuse, then you potentially have to withdraw them. Depending on how you formulated your consent, you may have to withdraw all the existing data or their samples. Or you could potentially go back and ask them to just consent to any new components, in which case any refusal might only apply to the new components. What's maybe one thing to consider is whether reconsent is actually the right term here, because if the child hasn't consented in the first place, it's probably better to characterize this as recontact and consent if they never consented in the first place. Next slide, please. So this, of course, raises the question of, well, when would you need to reconsent, or when would you need to consent a child that hasn't consented previously? And again, this is discussed in the TCPS2 at Article 3.3. And along with most of a lot of the literature on this, the consensus seems to be that children should provide their own consent when they're mature enough to understand the research, understand the implications and their participation. And so again, the specific discussion in TCPS2 in chapter 5 around how this applies to secondary use. And I don't have time to go into that, but I'll just direct you to that if you're interested. Next slide, please. So of course, this just pushes that question about when to consent further down the line. So when do we think about the age of majority? When do children accrue those necessary skills to be able to consent for themselves? And again, the literature varies depending on the context, the jurisdiction. There may be individual institutional policies. So again, I wouldn't take this as a hard and fast rule necessarily, but there does seem to be, certainly through the work of scholars at McGill, Bartha Knoppers and colleagues, an indication that the age of 14 is perhaps a good or useful threshold that's being applied. And I think that's, from their work, suggests that some of the work by the Statistics Canada, those large samples, they would be getting consent from the individual children at the age of 14. Obviously, the strength for Statistics Canada is that a lot of their work is going back to the same people over time. So they have the contact details. So the onus of making that contact and then getting the consent is perhaps less than a study where there was a one-time sample collection or one-time data collection, and that might have been 20 years ago. Next slide, please. So as I mentioned, there are opportunities to conduct research with data that's already been collected that allows for exemptions from consent. And TCPS2 again goes through a number of aspects of this, but it lays out a number of criteria that should be met if the research can go ahead subject to Research Ethics Board approval. So again, it's about showing that it's socially valuable and that the data that you have is necessary for that research, that the benefits likely outweigh the harms. So for example, that the participants aren't likely to be adversely affected, that privacy is maintained. So again, those additional protections around that respect for persons. The researchers comply with known preferences, again, respect for persons, any express wishes, and that it's impossible or impracticable to seek consent from individuals. So again, trying to strike that balance between socially valuable research and still maintaining those individual rights. However, a big area of discussion, not only in this area, but in terms of waivers of consent generally, is what do we consider to be impracticable? And I think there's a lot of work going on discussing that, and I'm not going to provide any guidance on that, save to say that it doesn't mean it's merely difficult. Next slide, please. So when we think about secondary use of routinely collected health data without consent, this means that privacy and confidentiality take on a much greater importance. And so a number of entities might require specific assessment of privacy aspects. Next slide, please. And so this is taken from the ICES website. And I'm just merely pointing out here that this ongoing piece that I've talked about between sort of individual rights and sort of recognizing the social value of research is covered even within the sort of privacy legislation, which allows that entities can put mechanisms in place to allow this research to happen even without individual level consent. Next slide, please. And so I mentioned privacy and the impact assessments. These will be specific assessments of any individual study, looking at those risks and benefits again and again. ICES as an entity that holds a lot of these data sets has developed these processes. So reaching out to these entities is probably a good first step if you want to do this sort of research. Next slide, please. So I mentioned we would talk about some options to address some of these challenges. And one of the ways that people have talked about addressing some of these privacy concerns is by using completely anonymous data. By using anonymous data, the concerns about identifiability are supposedly put away. But this needs to be traded off with the research question that you have. Can you actually address your research question with anonymized data that you can't necessarily maybe link to other sorts of data because of that anonymization? And increasingly, there's also concerns about what anonymization, is it truly anonymous or is it de-identified, and what are the risks of re-identification, particularly when we start to link these data sets together? So anonymization is sometimes presented as a solution, but it may not be the solution depending on your research question and what you want to do with different data sets. Another option is to work with a prescribed entity such as ICES that has appropriate privacy protections in place. This would allow investigators or analysts at that entity to work with the identifiable data and conduct analyses in accordance with your research question, but then you would only then receive a certain cut of that data. Of course, none of this removes the need for REB approval, although there may be differences in the way that research ethics approval occurs. It might be an expedited or sort of delegated review depending on the study. There are differences depending on whether you want to link in, say, clinic data that you've collected at your own institution to a large provincial data set versus just purely using a data set that's already held by the prescribed entity. And depending on the research ethics board, they may have sort of pre-approval processes in place, such they already have a good understanding of the privacy protections put in place for ICES, for example, and so the review would be very much just looking at the specifics of that study without necessarily reviewing all the privacy steps that have been in place. Next slide, please. And in terms of the practical implications, one of the things to bear in mind is, depending on what you want to do, you may not be able to have the data in the same degree of granularity that you may want. So, for example, many of these entities, so ICES or BORN, the Better Outcomes Registry and Network, as well as other data holders, they will have built-in algorithms or processes that look at the combination of variables you might want to use in your data. And you might be allowed to have certain combinations, but only at certain levels of detail. So you might not be able to get date of birth and 6-digit postal code, but you might be able to get year of birth and 3-digit postal code, because that reduces the risk of identifiability. A second aspect to bear in mind is the reporting. And commonly cell sizes, so data cell sizes of, say, less than 6 are often obscured or limited in terms of preventing identifiability. So you're not able to report out exact numbers when those are very small. And when we're thinking about child health research, this might be particularly relevant to sort of those working in the rare disease space. And at the end of your analysis, the work and the output might actually even be reviewed for privacy concerns. So work that's conducted through the Statistics Canada Research Data Centres is actually reviewed prior to it being released to make sure that it's compliant with all their privacy checks. Next slide, please. The third principle I mentioned at the start was around this principle of justice. And so I just want to briefly talk around some of the challenges around equality, diversity, and inclusion, particularly when we think about who's in the data, or perhaps more appropriately, who's not including in the data that's captured, how results are interpreted and used. And then I'm going to mention something called the Progress Plus framework, which may be particularly relevant here. Next slide, please. So a key question is whether the study samples data sets, because they weren't collected for our research question, but for other purposes, are they inclusive, or do they actually reflect the true population that you're interested, or the population you're interested in? So are there people, for example, who don't access healthcare, but have the condition of interest? For example, if it's a stigmatizing condition, then these individuals may not access traditional health services. And so if you're asking a question about those populations using a data set that maybe misses them, are you able to actually address your question? And does that affect the conclusions you can draw and the inferences you can make? And while consent and some of the privacy considerations might address some of our sort of individual level concerns, we also need to bear in mind that there might still be group level harms, even if we can't identify individuals. So for example, if we're sort of reporting out our outcomes by groups, are there concerns about group level stigmatization, for example? And the inferences we're making, again, thinking about association versus causation, and sort of what are the limitations to the inferences we can make from our data. Next slide, please. And I mentioned the Progress Plus framework. This is, Progress is an acronym based on considerations of different social determinants of health or contributors to social and health inequalities. And so these are particularly relevant considerations, I think, when we look at the data and consider, are these factors relevant? Are they useful for thinking about who is or is not represented in our data and what we can say about different slices of the population? Next slide, please. And I just want to flag Indigenous health research. I'm not an Indigenous scholar and I don't work with Indigenous health data, but again, this is taken from chapter 9 of the most recent TCPS2. There are ongoing sensitivities about using secondary data collected on Indigenous peoples based on historical misrepresentation of these peoples. And so I just want to flag this as a particular area where there's a need to engage with the community, work with the community, and there are processes that have been established by some of these entities to work with Indigenous health data. And so if this is an area of interest, then I would strongly suggest reaching out and sort of working with these groups. Next slide, please. So back at the start, I mentioned the 5 V's of big data, and I talked about veracity and said I'd return to this. Eric previously spoke to this group about sort of validation and the sort of scientific aspect, and I'm going to talk about some of the ethical aspects of this. Next slide, please. So when we think about veracity or the uncertainty or the quality of the data, it really does emphasize the need for validation. We may want to validate for a number of reasons. One, there might be data errors. Because again, that data wasn't collected for our purpose and we weren't involved in that collection, we're not really sure about the processes necessarily, unless they're well documented, about how that data was collected, input, and their error rate, etc. But there may also be missing data. And so we need to think about the implications that has, whether that's missing at random or not. And again, any of this might be exacerbated if we think about linking different data sets where all of these issues arise in each of those data sets. And so we have to think about all of these issues, as well as the overall fact of whether or not the data collection actually allows us to address the question that we have, sorry. Next slide, please. But from an ethics perspective, it also reflects a challenge due to the sort of decisions that follow from our research. There may be advantages or disadvantages to different groups. We may have erroneous results, and therefore that might lead us down a pathway of making decisions that perhaps if in other circumstances we would not have made. And subsequently articles may even be retracted, but how does that work in terms of sort of getting that information out of the healthcare system, out of that decision-making processes? It's not always as simple as a quick response to a retracted article. So again, this verifying the data and validating it is key because of these subsequent steps that will often happen based on results. Next slide, please. And so to kind of help us or try to address some of these issues, reporting guidelines have been developed. And whilst these may be thought of as a sort of scientific tool, they have an ethical grounding insofar as within some of our fundamental ethics guidance, such as the Declaration of Helsinki, it clearly states that all parties should adhere to accepted guidelines for ethical reporting. So that raises 2 questions. One is, are we? And the second is, what are the accepted guidelines for ethical reporting in this space? Next slide, please. So I mentioned previously this figure, but if we click through again, just to highlight that some of the key areas in this waste or inefficiencies in research relate to the reporting of research, and particularly the ability to make use of those reports. Next slide, please. And when we think of reporting guidelines, they can help us potentially meet our ethical requirements as set out in the Declaration of Helsinki for a number of sort of intrinsic and extrinsic reasons. Firstly, the way reporting guidelines are developed is often through expert consensus with people working in the field. They represent a sort of form of self-regulation, maybe de facto standards or professional norms that people are expected to then adhere to. And because they're self-regulatory, there's a desire by the community to be seen as open and transparent and honest. And that potentially goes back to this question of trust that we raised earlier, in the sense that if the public, patients, and other stakeholders see researchers as a group trying to adhere to best practices, then that may engender trust in the governance of this work. And again, make sure that people are willing to take part in research and contribute their data. Similarly, if their reporting guidelines are endorsed or even mandated by journals, then we can monitor compliance. We can demonstrate compliance and, again, hopefully facilitate that trustworthiness or develop interventions to try and improve compliance. Next slide, please. So I raised the question of whether we're meeting our obligations, and this was a paper conducted by Lars Hemkins, who looked at the reporting of studies using routinely collected data. And if we click through, please, and one more, you can see that they looked at a number of items that they thought or decided were relevant to the reporting of routinely collected data studies. And they found that for some items, yes, the reporting was adequate, but for a number of key aspects, such as you'll see the validation of algorithms, the data availability, how the data was linked together and so forth, they really found a number of items where reporting was suboptimal. Next slide, please. And so the step was to develop those ethical standards, those reporting guidelines. And this led to the development of the record guideline, and I think Eric may have mentioned this previously, but just to say this sets out a number of reporting items that investigators conducting research with routinely collected data should report. Next slide, please. And subsequently, there was an extension to this for studies using pharmacoepidemiology, or pharmacoepidemiology studies, should I say. And both of these are open access and available through the record statement website. Next slide, please. So I just wanted to give a case study or a quick example to kind of illustrate how reporting guidelines might be particularly relevant in the place we find ourselves at the minute. And I need to credit Eric Benchmel here for sort of flagging this. And I think Eric is working on a manuscript around this. I'm not sure if it's in process or not, but I should flag him that this was his suggestion and he pointed these out to me. So next slide, please. So I'm not going to go into the details of these studies, but just to say that they were two pharmacoepidemiology studies that used routinely collected health data. This was a range of different data sets, and they were published in two very high impact journals, the Lancet and the New England Journal of Medicine. And I'm not going to, as I say, I'm not going to go through the studies in detail, but just to say that the studies suggested that COVID-19 patients on hydroxychloroquine had a significantly higher risk of death. And this is important because if we go to the next slide, please, there were a number of immediate responses to these papers. They influenced policy by the World Health Organization. They suspended testing of the drug. There were changes to trials that were in recruiting, and there were changes to guidelines. And if we go to the next slide, please. As you're probably well aware, these studies were then retracted based on primarily concerns over the verification of the data. Several readers and other scientists had pointed out potential flaws, and when it came to it, they couldn't verify the data that was underlying the papers. So these were retracted because of those concerns. Next slide, please. And in this later piece that that reviewed the two papers and the retractions, one of the areas they flag as a missed opportunity was the potential for peer review to catch some of these. And so the question is, could the reporting guidelines potentially have helped with this? Next slide, please. And so these studies were pharmacoepidemiology studies, so they were key, they fell under the rubric of record and record PE. And in communication with Eric, he explained that they've looked into these, and these studies were deficient in a number of items that are within those guidelines, particularly around those aspects around validation and so forth. So we could argue that the use of reporting guidelines in that peer review process may well have caught some of these issues that were subsequently highlighted, and may have either led to the non-publication of these articles or amendment or so forth, which could potentially have averted some of those delays in trials, wasted resources, and so forth. Next slide, please. And so I'd just like to summarize before I finish, if we go to the next slide, please, that I hope that we could discuss a number of the challenges that arise in the context of routinely collected data research in child health. And we talked about consent, privacy, equality, and diversity, and the social value, and how some of these may require striking a balance between those individual rights and collective rights. We talked about some opportunities and challenges, as well as sort of steps that we could take to address some of these concerns, particularly around privacy, ways to work with data, and so forth. And we also talked about some potential resources, particularly the SPOR support units, ICES, and reporting guidelines, the record guidelines and record PE. So if we go to the next slide, please. All that's left to say is thank you very much, and hopefully we've got some time for questions. Thank you.
Thank you, Stuart. That was an excellent presentation. Very, very timely for my lab as well. I'll apologize to everybody in advance. I'm back to back, as many of us are, so I do have to go right at 1. I wonder, is it possible for us, Linda, to stop recording during the Q&A? Because I have some things I want to discuss with the group and with Stuart online, but then I'm not really comfortable with being recorded. So